Good afternoon, everyone, and welcome back to Medical Festival Asia's afternoon session. We are honored to have today with us Dato Jacob, who will be discussing risk management within the hospital setting. Specifically, we'll go over how hospitals manage their risk, and in turn, of course, the risk exposure of patients. We'll look at how risk management is associated with enterprise risk management systems, the process of risk management, and of course, the key role that safety culture plays within this. With regards to Dato Jacob is the Group Medical Advisor of Ramsay Sime Darby Healthcare. He is both a medical doctor and has extensive experience within the patient safety realm. He was formerly the president of the Association of Private Hospitals of Malaysia, APHM. He has also been a councillor for the Malaysian Society for Quality in Health, MSQH, a member of MHTC Council, and of course, Dato Jacob today works closely with various NGOs and government to promote Malaysia Healthcare, one that he is looking to really push forward through patient safety standards, through risk management, and this has only been further cemented by Dato Jacob having been appointed to the board of directors of Joint Commission International, JCI, for the past 6 years. So, Dato Jacob, thank you so much for being with us today afternoon and sharing your insights on risk management. The format for today's session, as you know, would be your deep insight and a presentation from yourself, after which, if you would allow just a few minutes for me to do a Q&A with you so that our audiences and the questions they're asking, I will share them with you after the presentation. So thank you again for being with us, and let me pass the floor to you now. Thank you.
Thank you, Varun, for this very generous introduction. And also, I'm grateful to Global Health Asia Pacific and Messe Dusseldorf Asia for this opportunity and honor you've given me to present at this Medical Festival Asia Summit. I always look forward to your organization and both your organizations for an opportunity to be part of you and to talk about healthcare. Now, today we are going to talk about risk management in hospitals. This is a topic which I'm personally very, very passionate about. I will explain as we go on, and some of the stories I'll tell you as to why this is so important in hospitals and for us to look at giving this importance. And I cannot overemphasize the fact that risk management in hospitals is very, very key, whatever time it is, not just during this pandemic, but even at other times. Now, today's agenda, we'll be looking to understand risk management and enterprise risk management. These are terms which we'll explain in a while. I'll go on then to look at the risk management process, and then the risk management plan, and finally to look at safety culture and risk management. So first of all, let's look at what is risk management. Healthcare risk management comprises the systems and processes employed to uncover, mitigate, and prevent risk in healthcare institutions. We have to work hard to uncover, and only then we can mitigate and prevent these risks. Now, enterprise risk management. Traditionally, risk management in hospitals focused on patient safety and medical malpractice concerns. That was how it was for a long time. But today, it is important, and what hospitals look for is risk management is much more comprehensive and can be seen as involving 8 domains. And I'll elaborate a little more in the next slide on these 8 domains. First of all, we have clinical and patient safety domain, one of the first things. And I've put that first because it is one of the most important. Now, I can tell you stories, and we will listen later to a video. And there are many clinical and patient safety areas where risks are so embedded. And one area I can tell you offhand, just to start off my stories, which I think is the best way for us to learn, is a hospital in the UK. I won't name the hospital. As you walk, it's an educational institution. And when you walk into the lobby of the hospital, you see a showcase or a cabinet on the right, a glass cabinet with a leg, a preserved leg in that cabinet. And at the bottom of that, there's an inscription by a world-famous orthopedic surgeon who's written there, "I removed the wrong leg. I hope you do not make the same mistake." Now, this is by a world-famous surgeon, and he is put it there admitting that he made a mistake, and the students he teaches and all those who pass through the corridors will not make that mistake. So this is one of the ways in which we teach others to avoid this risk. We also have strategic risks. Now, strategic risk is something we need to look at because we want to see what services we want to provide and how do we provide these services. We look at new directions to take in a hospital. Now, are these directions safe? Are they without risk? Are there things we need to know when we embark on these strategic directions? The next area we look at is the financial risk. When we adapt to situations, we have to look at how much it costs. Is this something which the patients we treat can afford? What is the pricing? What is the marketing we need to do so that we can mitigate this financial risk? Financial risk from the point of view of a patient and also the institution you are involved in. Can they sustain the practice or the business? The next thing we look at is staff training or human capital. Staff training becomes so important because healthcare staff are specially trained and have to have the mindset which helps to look after patients. So we have to look at human capital, make sure we protect them, make sure we are able to retain them. We hear very often of a brand new, fantastic hospital opening, but all the staff left and went to a neighboring hospital. So human capital, the risks involved are important. We also have to look at legal and regulatory issues or risks. And we have to give a lot of attention in today's environment to malpractice. And especially when you try and cut corners, are we taking risks and compromising on patient safety? We look at technology, and I think in this environment, we look at connectivity, we look at Zoom. Are there limitations when we involve in Zoom and online consultations? And we introduce new technologies, and whether that is of benefit, whether they are risk, whether we know and we know about this technology, and whether the staff using this technology is adequately trained. And when we also have to consider some of the old technology, have they become obsolete? Have they been well maintained? These are all issues which we need to look at. The next one is about hazards. This is again something we see very often in our environments. There are times when hospitals are covered by flood waters, access is limited, or they are involved in some mishap because of some war and hospitals are damaged. How are the patients being cared for? Do we have to transfer them out? Or in like current situations in a pandemic, do we have enough staff Are the staff well equipped? Do we have enough medicines? Do we have enough ventilators? And other issues when we look at hazard. And we look at operational issues. How is the hospital being managed? Are there adequate checks and balances? Are there ethics? Are there clinical practice guidelines in place to make sure that the operations of a hospital is going on well? Now, the process of conducting risk management in hospitals, first of all, we have to identify the risks. I think we talked about this. Without identifying the risks, you won't know how to do risk management. You have to look for it. We have to have adequate staff to be able to be positioned to look for these risks. You have to have committees to, once you have identified these risks, to discuss these risks and how do we mitigate this risk. Very often today, the board of directors of hospitals are very concerned about risk management, and they want to know these risks and are you managing this risk well. The next area is to look at quantifying and prioritizing these risks. What is important? What can wait? Which are the ones we need to look? I'll explain a little more in the next slide about prioritizing this risk. We have to also investigate and report sentinel events. Hospital heads, the directors of hospitals, and even the ministries of health often want to know, especially sentinel events. Are these events happening too frequently in this hospital? Is something wrong? We need to look at that. And this is a requirement by many governments today, that their ministries of health keep a watch on hospital and their risks. We have to capture near misses and learn from them. Now, it is important that near misses are recorded and we learn from them, because these are valuable tools. It's a warning sign. Near misses, it is not an incident yet, but it could cause a problem in future. So we have to identify this. We have to also identify latent failures. What are the things which have gone wrong? We have to analyze the errors using root cause analysis and failure mode effectiveness tools. This is not to blame someone. It is a process to look at failures and which processes have failed. Do we need to change that process? Now, many organizations, and there are tools available, risk management information systems. I know of one tool which is called RiskMan International, where they are able to analyze risks and the causes, and we can help to prevent these risks. And lastly, we need to look at the finance transfer, or if the risk is going to be retained. Now, this is the metrics for risk management. And if you look, we look at the impact and the frequency. If the impact is low and the frequency is low, then it's a low risk. It is in the green area, right on the left bottom. But if it is a high impact and the frequency is high, then it is on the right upper corner. And this is something which creates an alert for many organizations. And these color-coded marks are very important for organizations to have this traffic light system where you monitor risk. And is this a red area or is it a green area where you just keep an eye? And this helps us to go forward. Now, the risk management plan, and we look at the actions and we want to find out what is the things we need to look at. We want to look at risk management, the purpose. The purpose of risk management is to protect patients, staff, and visitors from injury. So patients in the ward, we also have to pay attention to the staff and to visitors. And we see this very clearly in the current COVID pandemic, where patients, yes, are protected in whichever ward they are screened. Staff working have to be given proper PPE, and they are also regularly screened and given education how to prevent themselves from getting the infection. And we restrict visitors, or if they really have to come, then we make sure they know how to protect themselves from catching the infection which is lurking in these hospitals. We also have to protect the financial assets and reputation of the organization. That is also important. We have to make sure that we look at how we can make sure that there is no damage to the organization because of a disaster. We have to make sure that the reputation, especially because of complaints or because of unethical practices and causing risk to the organization, we have to look at the reputation. The plan is the tool to run the risk management program. Now, we have to make sure there's a risk management program in place. And as I told you, there have to be individuals responsible, there have to be a committee, and it goes all the way rightfully to the board who have to keep an eye on this. And the plan is to provide continuous, comprehensive, and systematic approach to reducing risk. The aim should be always continuous and to reduce risk. It is not a one-off situation where you just do it once and forget about it. So that is the whole purpose of it. Now, what are the actions you take? You have to provide education and training to staff, to doctors, and whoever walks through your organization. We have to make sure this education, we have to equip staff to avoid or mitigate the risks they are encountered. We have to respond to patients and family grievances. Sometimes it's so important to have a timely response. We avoid, first of all, litigation by doing that. The other thing is sometimes the patients or visitors or the family will tell us what is happening to the patient, and that information sometimes is valuable to prevent harm to the patient. Now, it also includes goals and metrics. I'll emphasize this a little later. We have to have a communication plan and communicate to staff and to patients, and we have to tell them what are the causes for risk, what are the problems we face. We have to have contingency plans in case of catastrophic events. I told you about disasters. We have to know how to look at the different aspects of weather, cybersecurity, pandemics. I think we are all quite familiar with that. Now, there have to be reporting procedures. We have to have a system, whether it's online to the whole organization, how it's escalated to the board. We need to report to the ministries of health. We need to report to the headquarters of your group of hospitals. And there are various people who need to know this, of course, to the CEO as well. And there has to be an appropriate response and mitigation once this is reported. Now, safety culture and risk management is also another aspect we need to look at. Most errors in hospital result from a faulty process. I want to repeat that. Most errors in a hospital result from a faulty process, not incompetent employees. But the culture in healthcare very often, sadly, is to blame the individual associated with an error. So we need to work towards a safe culture that celebrates and expects reporting errors near misses, and good catches. A safe culture is central to becoming a high reliability organization. This is an organization which many of us aspire to work in. We want to report when we think something is going to go wrong or something has gone wrong, but we are able to work together to rectify it, to make sure it's safe in the future and it doesn't happen again. Now, the definition of a safety culture is a safety culture within a healthcare can be defined as the summary of knowledge, attitudes, behaviors, and beliefs that staff share about the primary importance of a well-being in the care of patients they serve, supported by systems and structures that reinforce the focus on patient safety. This is a statement by the US Joint Commission. So it is not just a one-off situation. It's a summary of the knowledge, not just knowledge. It is also of the attitude and behaviors and beliefs that staff share. So all this make up what is called a safety culture, and it's not just one person doing something right, but the whole organization have to do it right. Now, one other aspect which I cannot overemphasize is leadership and safety culture. The organization's leadership creates the culture of an organization. The leader's behavior tells the employees what will be tolerated and valued and what will not be tolerated. It is leaders who create a safe reporting culture in a hospital, where the reporting of errors and near misses is expected and not blamed. More reports of errors and near misses tell you what you need to work on. I always tell organizations where many errors or near misses are reported that your organization is a safe organization and that you have a safety culture. Now, I want to just say this is to make it clear. A safety culture depends a lot on the leadership. Without proper leadership, there cannot be a safety culture. So it is, first of all, a question of trust. The employees trust the leadership that it is safe for you to report near misses. You have to report because only by reporting you can look at what happened, what processes went wrong, improve, and this is a continuous cycle. So leadership plays a key role in a safety culture in an organization. Errors and risk management, a key metric for risk management program is the number of reported errors and near misses. You cannot mitigate or measure a risk or identify a risk that you do not know about. So it is the number of errors and near misses reported that give you a guide as to which areas are not safe, how often is it happening, and that will help us to mitigate the risk. A safe culture will motivate and encourage more reporting and the opportunity to reduce risk in your organization. Now, I want to show you this video because this is something, they say a picture is worth 1,000 words, but then this is a video which speaks volumes. Every time I watch this, it gets me emotional. So let's look at it before we go on with the presentation.
Hi, I'm Alicia Cole. I'm an actress. I live in Los Angeles, California, and I've been an actress, been in the Screen Actors Guild for 19 years. In 2006, I found out that I had fibroids. So I thought, okay, well, if I get these fibroids taken out in August, I'll be healed, I'll be ready for the start of the television season. I was supposed to be in the hospital 2 days in and out. I had the surgery, but I never got better. It just spiraled from there. My breathing started becoming very labored, and my heart rate just went crazy. My abdomen was flaming red, and it was hard like cement, and it was on fire. My mother saw a black dot, like you took a Sharpie marker and just gently went like that. It took the doctor about an hour and a half to get back to the hospital, and he said, oh my, okay, now we need to be concerned. The black dot was like the size of a quarter. It looked like my skin had melted. He looks at my mother and he says, Mrs. Cole, are you squeamish? And my mother said, no. And he said, good, because I need you. I was terrified. To ask my mother to assist him and not wait and take me back to the operating room in a sterile, clean environment, to take a tray with gauze and put it in the windowsill overnight, and then take that same tray, lay it across my legs, and start pulling gauze out of an already open box. And they basically use their hands to pull open my incision. I've never felt that kind of pain, ever in my life, ever. The infection was spreading about 1 inch every hour on the surface, so even more underneath. So the infectious disease specialist should have been there that night, but she didn't come until the next afternoon. No one really paid attention to the signs and symptoms that I had. In that hospital, starting from the top down, there was a lack of consideration for the patient. It wasn't until after that, a few days, that the doctors verbally told my parents what I had. Sepsis, Pseudomonas, VRE, MRSA, and necrotizing fasciitis, flesh-eating disease. It was an indication of a total system breakdown. I was in a prominent, beautiful facility. I did my homework. I did what an engaged patient is supposed to do. I was proactive. But my 2-day hospital stay for routine fibroid surgery went from 2 days to 2 months in the hospital, a month in ICU, 9 blood transfusions, 6 additional surgeries, almost having my left leg amputated. I had a year and about 2 months of twice-a-day home health care nurses. I had an open abdomen for 3 years that would drain. Physical therapy off and on for at least 4 years. Doctor's appointments every week for the last 7 years. And over $2 million in medical bills. I used to have a lot of faith in the system. When I see what's happening in healthcare and people who it's just a job and coming to take care of a woman who's missing her abdomen, and I don't bother to read her chart before I get there. Or I don't bother to wash my hands. That kind of thing hits me at my core because it's not how I was raised or who I am. We believe in honor and loyalty and truth and standing for something, no matter what the cost. My life is completely different. It's, I was a cheerleader, volleyball, basketball, softball, ran track, bowling, you name it. So that's real hard. I had the most amazing support system going through this. It's what saved me, literally what saved me. There are so many patients who are by themselves, and that's why it's so important to me to speak out, to advocate, to give back. And I'm very, very proud to have been a part of the 2 laws for public reporting of hospital-acquired infection rates in the state of California. Our hospitals are scary places. Our healthcare system is broken, but there is hope. And that hope is patience, patient engagement, patient involvement. Albert Einstein says, you cannot fix a problem with the same mindset that created it. Patients bring a fresh perspective. We are the secret weapon, the magic bullet. Patience will change healthcare.
Well, ladies and gentlemen, I'm sure that was a very, very moving video. I've watched this video maybe in my presentations and otherwise about 30 or 40 times. But each time I see it, I feel so emotional that this can happen in any of our hospitals. And how, doesn't matter how good your hospital is or how good it looks, if there's no commitment and there's no leadership to make sure that our patients are safe and that we look at all the risks involved, I think systems will break down and we will have situations like what we heard. So my final thoughts before I end is risk management in hospitals is hard work that requires time and attention. It's not a one-off statement or a opening statement when you come into a new job in a hospital. It is a continuous process and it requires a lot of effort and a lot of time. To be effective, it needs the attention and support of leadership and the entire organization. I've been in organizations where the leadership was not committed to patient safety and to risks involved and things don't work. But I'm proud to say in the organization I'm in now, that leadership has made the change right from the board. And the changing the culture could take years. It's not something you fix overnight. But the returns to your organization and more importantly, the increased safety of your patients are worth it. And it surely requires this effort. So risk management in hospitals is not just a passing thing you do in your career working in a hospital. It is something embedded in the organization, which is an integral part as much as any other service that you have in the hospital. So I just want to leave you with this saying by James Reason. We cannot change the human condition, but we can change the conditions under which people work. So I've left some references for you as well. And once again, I thank you all for your attention. And I hope you learned at least a few things from this very short presentation. Thank you and have a good day.
Thank you. Thank you, Dr. Jacob, for that very, very insightful presentation and that touching video. I think it really helps resonate with everyone in the industry because we are experiencing, and especially this year, just a sheer range of stresses and pressures put on the systems, which only likely further highlight the difficulties. And if there are cracks, they do show. And I think, you know, if I can say so or paraphrase, it seems that safety culture and risk management really is all about processes, culture, and of course, leadership, as you mentioned. Throughout the session, we had a few questions popping up in the chat, and I wanted to take this opportunity just to spend maybe 5 or 10 minutes to go over some. And so I think one of the areas that were highlighted in the chat were, there was a lot of discussion around near misses. And I think, yes, everyone agrees that if you are able to capture near misses, they prevent an eventual disaster. But how does one go about catching a near misses? How do you quantify what a near miss is? How do you embed that in a hospital's process that this is a near miss, this is not a near miss? If you could maybe share more insights on maybe in your experience, how have you put parameters around what is a near miss and to be able to capture that information?
I'll give you one example which will be able to illustrate what I mean by near misses. We can talk about, my first story was about removing the wrong leg. But we have got instances where we get reported from our theatres that the patient was taken to a theatre and the eye was prepared for surgery only just before the incision was made. The nurse shouted, "Doctor, it's not the right eye, it's the left eye." That is a near miss. So these are things which have happened. Unfortunately, the near misses are not always there. Sometimes it's like that leg which was removed. The normal leg was removed and the diseased leg was left behind. That means that patient is going to be left without legs. That's the actual thing. The other area I can tell you again is, example is near misses in a pharmacy. When nurses dispense medications, they think or they saw the thing which is, you describe it in medicine as look-alike, sound-alike. It might be ampicillin, but it is some other name with some other cillin. And you think it is the medicine and you want to give it. But you almost gave it, but when you counter-check or another nurse comes and checks, you say, "Hey, this is not the patient for that medicine. It is the next room." So it is a near miss. So what we tell our organizations, or what we hope leaders will tell the organization, is to inform management or the people who are in charge of risk management what are the near misses, so that we can re-look at it is not the person's fault, but the process wrong. So that is two examples of near misses which we can look at to save. But together with near misses, we have also to look at something else. We won't get reporting of near misses if there's no culture of a no blame culture.
Right.
When you report a near miss or even a mishap, there has to be a focus on the process and not on the person who was involved in it.
I think for 2020, one of the strong positives that we would take moving forward here is this year, unlike any other year, has really highlighted the selfless sacrifice that healthcare professionals have made for the community. And I think from there, we can really see that any mistakes that do happen in healthcare are not the person. And I think exactly as you said, often based on processes, and the processes that catch these issues and help create a safer environment and have risk management, which maybe builds onto my second or other question that people were asking is, when you're implementing risk management processes, it seems to be something that has to be top down. And especially today where multiple hospitals are a group of hospitals, policies are hospital-wide, group-wide, a lot of it is driven also from a financial perspective. How do you manage the financial aspects? Because I am assuming, or we are assuming, that the more processes you put in place, the more checks and balances and documents, all of that are an additional cost. Are there, in your mind, or have you seen the financial returns to implementing a better risk management? And how do you convince senior management and boards to bring those processes into the hospital? And where do finances play a role in risk management?
No, I'm a strong believer that if you take care of the risks, you take care of the patient's safety and their well-being, the finances will take care of itself. Because what you're doing is making sure that the outcomes are good. You're making sure that the patient is happy, the family is happy. There's not going to be any litigation. I sit on many committees where we look at grievances from patients who've not been attended to properly. They are saying, why haven't the hospital explained to me why this mishap happened? So communicating with patients, going with them every step of the way and explaining to them the risks involved in a particular surgery, A to Z, giving them the decision, these are the risks involved. Can you tell us, are you comfortable with us proceeding? Right. So when you talk about finances, I explained in one of my slides that if you attend to grievances, if you attend to the risks, your litigation, your mishaps, your re-surgery, your additional cost for infection which has come in will not be there. We saw in that video, this was simple fibroid operation, which normally takes 2 days. But she had to undergo treatment for 1.5 years and cost over $2 million. So are you talking of financial risks there? Who is going to bear these risks? I think if you talk of healthcare systems today around the world, many of these systems break down because unmanaged risks, and we are not conscious about how we mitigate these risks. So finances are very important, and if you take care of the risks, you give attention to it, and the leadership, starting from the board, gives a lot of importance to these risks. We will find that those organizations will do well. It might be difficult to talk to patients and to staff who come up with these issues, but I think it's worthwhile. As I said, patients will benefit.
And I think, as you mentioned on the litigation, I think if people understand that if the litigation risk is mitigated, the doctors themselves will be less afraid, and the safety culture and the reporting of near misses should increase because you're taking away the negative downside or the risk impact to them. And I think that kind of helps build on its own. Do you see the doctors, as soon as they start the safety culture or near misses, a change in their mindset and in adopting and then actually encouraging more reporting?
I think, Varun, in today's healthcare environment, especially when we talk about Joint Commission International and other bodies which look after patient safety and infection control and things like that, you cannot differentiate the roles between doctors, nurses, the staff, the people, the attendant who pushes the patient. All of them have equal responsibility, and they all have to understand that each one of them have got a role to play in making sure that the patient is safe. So the pharmacy who sends up the medicine, the nurse who hands over the right medicine or the lotion to the doctor, and so it goes on. Of course, each one has to understand their individual role to make sure that the patient is safe. So that's why it is emphasized. It's not an easy process. It's a long, drawn-out process. But once you have that culture of safety and you have that culture of being able to openly discuss these near misses and mishaps, you will find that your organization is on the way to being one of the top organizations in the country.
Understood. No, definitely. And maybe on, we understand the obstacles to implementing risk management, but again, going back to 2020 this year, I think with the amount of changes that hospitals have to make have made because of COVID, that would have also led to a lot of process changes. Has COVID impacted the processes that were implemented in hospitals for risk management? Have you had to change processes? I'm assuming the buy-in would have been there, but maybe on I guess, just more of an anecdote or sharing, have you managed this year in terms of changing the risk profile because the typical operations of a hospital would have been very different? Or has your group maintained relatively normal operations because the patients coming in are still coming in for the same reasons, elective care, critical care, and so the processes have not changed, but everyone is just so much more aware of managing the risk? Could you share any details maybe on how this year has been for your group?
I think one area I want to emphasize right from the beginning, the aim of management was to make sure that our staff and doctors were safe, that they were well given enough information about how to remain safe, and they had the right equipment, personal protective equipment to do that. Secondly, the patients who came into the hospital were also assured that once you come in, you are safe. And so that's why many of our hospitals took a big drop in our finances because only urgent cases were handled. Many patients, some hospitals dropped as much as 50 to 60% of their normal volume because they were very, very selective in which patients were accepted for treatment. And every patient which went into the operation theater for an emergency or for an elective procedure had to have a COVID test to make sure that they are safe and that the staff know the status, the COVID status of this patient. So even if it is an emergency, the COVID test, normally the results take a few hours, or some early stages, it took 24 hours. So when you admit a patient, every new patient admitted with an unknown COVID status is considered COVID positive till the test results come back. And Only patients who are safe are treated in the operation theater, and we make sure that not only the patient, but the rest of the staff and the people around, including the family, know that the patient is safe to be visited.
So I must say, it's commendable because everything that you're saying, we saw that happen in Malaysia. We have reports from the government on the numbers for patient care, medical travels, and like you said, it may have dipped, but that investment that both your group and Malaysia made into taking the safety of first approach, Q3, Q4, just the demand that has returned to private care and the trust that's built into the industry. I think even from a financial aspect, the patient trust aspect, I think it is tracking as per last year or better. And I think that short-term investment and doing the right thing is really, the numbers speak for themselves. So, you know,
Varun, I can add that for our group,
yes,
the main hospital we have, our volumes dropped about more than 50%. And today, with all the measures we have in place, it has come up to more than 80% of what it was pre-COVID. And that is commendable because we are able to continue, and the patients we treat, the families and the community we are situated in is confident that our hospitals are safe and that we do these measures. So this is something which we create an awareness. And also our doctors are confident they have the right tools and equipment to make sure that our patients and the staff and everybody else around is safe. So we are very grateful to our government who have helped us a lot in bringing in some of these practices, and we are happy.
Honestly, and this will make it.
I must also add, Varun, that, you know, medical tourism, yes, was a major contributor to our economic situation here. But because of this COVID, there are hospitals which have lost 60% of their patients who came from abroad. But they were able to re-look at how else they can cope, how else they can make ends meet. And we were able to find new ways, new innovations. So in certain ways, yes, COVID has helped us. We have resorted to telemedicine and teleconsulting. And so these are things which have cropped up now, which will continue post-COVID and make it easier for patients to be reached even in their homes. And these are things which the good side of the pandemic.
The learning this year, of course. And I think that's exactly it, that the trust that's being built up, the return of patient flow, the fact that it's already at such strong levels compared to what it was, is just very promising for when medical tourism comes back. It'll be at a completely new height. And your group's positioned yourself very well for this. And again, that safety culture lends to the quality, because this year, safety implied a lot of quality of care, and no better time. So Dr. Jacob, if we could end today's session with maybe one last key takeaway or question, which would be, if there is one important thing in healthcare leadership, what would you advise that to be and to look at for everyone listening in today?
I would say the most important leadership in my 35 years being in this hospital is you have to be there for the staff and show them that you care for them. And if you lead them and tell them that we need these things from you to make sure that you are safe, your doctors are safe, your patients are safe, they will listen to you because they know where you're coming from and what you do. So leadership is so important. If they know you are genuine and that you want to make it easier for them to treat those who are not well and in a safer way, they will work with you and they will stand by you to take you to greater heights. And I think leadership is so important in this aspect.
Thank you. Thank you, Dr. Jacob. If I could say thank you for your leadership, for imparting this information on risk management to everyone tuning in today. I also want to thank everyone for tuning in to today's session and listening to Dr. Jacob. We've touched upon in this panel many points on culture, leadership, processes that we'll be taking away, and of course on telemedicine, different process flows, medical travel, which over the course of the next 8 to 10 days, these are the topics that we will be really building upon in further depth. So please tune in, and thank you everyone. And again, thank you, Dr. Jacob. Sincerely appreciate your support at Medical Festival Asia.
Thank you for the opportunity, Varun.
Take care. Thank you so much.